Well, thank you. That was a fantastic review of complications, and I only wonder, how Mazen, how you come up with all those complications. It's amazing. So I think what we should do is go around the panel here and ask a few questions of people, and get people's opinions about what they think about the best way to obtain access. Does everybody on the panel use ultrasound for access? Let me start with Peter Monteleone, who I left off of my introduction. So, Peter, tell me about what you do. Are you using ultrasound for every case now?
Absolutely, Kenny. Ultrasound everywhere, and both to assist with not just finding ideal locations, to optimize your opportunities for closure devices later, and also just to improve your skill set as well as that of your trainees with ultrasound. So, though 90% of radial arteries can be acquired fairly easily without ultrasound, 100% are acquired with ultrasound to give us the opportunity to improve our skills, improve our actual arteriotomy location, and just get better and better every single time. So 100%.
So, Chris, are you the same way now? Being an old dog before ultrasound even existed on the planet?
So the trouble is, it's my fellows who are doing the sticking, not me. So I completely agree that fellows are very fast up using ultrasound guided, both for radial and femoral.
Yeah.
There's not a good reason not to use ultrasound.
Yeah. So, Shirling, what are your sort of tricks and tips for getting good access and avoiding complications? I think that access site is the first and foremost complications that I worry about. It's every case. So, what are your tips and tricks to avoid them?
Yeah, so I do both. I fluoro to find, like for groin access, I fluoro to mark the femoral head because I think it's sometimes hard to see that on just the ultrasound. And then we use ultrasound to, identify the profunda. You can often see the inferior epigastric on it, and to make sure that we're sticking on the anterior side of the artery. But we use both.
Mm-hmm. Okay. So, Kumar, any thoughts based on those complications we saw from Mazen?
Yeah, I think that was a great review. For me, especially in IR, there's 0% chance of not using ultrasound. I think there's no reason not to. We like to adopt transradial for a lot of procedures because of concern for femoral complications, but I argue that femoral complications would be less if you had a set routine, safe access every single time. The other thing I train our fellows and residents is every single time they get access, just to be safe, especially as we walk in later in the year, halfway through, is just put the inner three of the micropuncture, shoot an arteriogram. That way you know what things look like in the beginning. You can always be safe with that. You can always hold pressure for 3 minutes, get a new access if you don't like it. So I think as a learning process, there's no harm in just sticking the inner three, checking everything. You have proof of what it looked like before you started. You can be confident about your closure at the end as well.
Yeah. So Eric, having been a relatively recent graduate, although you're already mature beyond your years, now I always worry that our fellows aren't getting enough experience with femoral access now because everybody's doing radial, at least in the coronary world. So do you feel competent to having, of course you did a vascular medicine fellowship, so I think you're pretty comfortable, but do you worry about that with your fellows now?
Oh yeah, I think that's a real issue. And we see this really clearly with our first year diagnostic fellows come in the lab, and even our first year interventional fellows come in the lab. We're at least 90% radial for our primary coronary procedures. And I do probably about 10 or 15% radial peripheral procedures now. So everybody knows how to do radial. And I remember working with you where I felt more comfortable doing a coronary case femorally in 2012 than I did doing a radial case. So I've spent a lot of time, I'm in the room with them getting access. We're practicing ultrasound. And again, back to Kumar's comment, we are reviewing a systematic way to getting femoral access so that they can be reproduced both in times of calm and in times of stress. So I think it's really important because, sometimes when we're doing complex coronary cases or peripheral cases and we need alternative access, the biggest mistake you make when you're in a rush is rushing access, because then you're just create more problems that you can't get out of. So we really practice doing it in a steady, measured fashion so that it can be reproduced even when, things don't go as planned.
So, Bala Raman, I'm sorry, I didn't realize we have more panelists than I realized. So, welcome. Do you have any thoughts about femoral versus radial, and are your or maybe you could describe what you remember as a complication that's sort of ingrained in your mind and how you dealt with it? I don't know if that's a little bit putting you on the spot, but
Well, generally, to answer your first question, we do femoral access more commonly in vascular than radial. But we do a lot of upper extremity accesses too. And I want to just comment on brachial access since that hasn't been touched on yet. But we do a fair amount of brachial access, especially depending on if the patient has had previous abdominal surgeries that make femoral access difficult. And brachial access, I think, is one of those that you have to be really careful about, because I do remember that, we had an uneventful case of an SMA stenosis that we put a stent on, and then the patient went to the floor, and then, he got numbness in the median nerve distribution and had to go back to the operating room to get a brachial pseudoaneurysm fixed. So brachial access, we are, especially important. Especially what we do is, what I do routinely is when we put the needle in, I make sure that it's against the humeral epicondyle, so that I have a bone to put pressure against, and then I routinely do an angiogram. It's the same thing for femoral access too. I make sure that I'm against the femoral head, and then do a routine angiogram. So I think routinely doing an angiogram at the axis and making sure that the axis is against a bony landmark is really helpful to avoid complications.
So I don't see the pictures of that. Those are great comments. I'm going to ask maybe Subhash, you nowadays, speaking of brachial, and by the way, then we move up to axillary, because now in the coronary world, we're doing a lot more axillary access, at least in selective cases for Impella and other devices. I have a patient of mine that had an axillary access at an outside institution, and it was had a hematoma that night, and it was ignored, and ended up with horrible chronic pain in his arm, and he actually cut his arm off. It was so bad, he cut his arm off. And now has a prosthetic arm, and of course it didn't eliminate the phantom pain, so that's been treated with other ways. But so getting access right that's the ultimate tortured access. But Subhash, do you have any hints about there's some beautiful descriptions of axillary access and where to obtain it, how to obtain it safely, and so on? What are your thoughts about axillary?
In the interest of time, Kenny, I will be very brief in my comments. I have two vascular surgeons who are very polite and courageous because they deal with my complications. They're on the panel here, Dr. Raman and Dr. Sai. But axillary access, and any axillary access or any vascular access with ultrasound should be done before the patient gets on the table if it's a difficult access. I cannot enough times avoid complications by doing this ultrasound imaging before the patient gets on. Second is that I try to get the axillary access in the third segment of the axillary artery that is distal to the takeoff of the subscapularis artery. And I know there's a limitation to it, but the advantage is that it is right on the humeral head. And Dr. Sai and Dr. Ramanan would tell me that we actually spend time ultrasounding the axillary artery and to delineate the nerve plexus on top of the artery. And you can say that if you are good with ultrasound, you can actually determine those. So I think there are some ways to avoid. And second, we always have a contralateral radial or other access. So we have a wire down that artery. And in one of the situations, I had to actually balloon tamponade after the perclose was deployed and the closure was not perfect.